Hello and welcome to the Clinical Care Options podcast on hot topics in NASH. I'm your host, Zachary Schwartz. This series features experts in endocrinology and in hepatology covering the latest in screening, diagnostic tests, evidence for diets, and treatment, and each one is followed by an in-depth question and answer session. Today's episode is entitled Weight Management in NAFLD and NASH. During this episode, Dr. Rotonya Carr from University of Pennsylvania Health System will answer the question, what should our patients with NAFLD eat? For more information on Dr. Carr and for a link to additional online education on NASH from Clinical Care Options, please visit the show notes for this episode. You can also go to the show notes to see the slides that accompany this podcast. Now let's get started and hear about the evidence behind different diets in NAFLD and NASH with Dr. Carr.
I am very excited to talk to you all this afternoon about our dietary recommendations for weight management in our NAFLD and NASH patients. But just to make sure that we're all on the same page, and I suspect we all are, just a reminder about the spectrum of NAFLD. We should recall that a normal liver has less than 5% hepatic fat. So fat is always in the liver, it's just not excessive. When we describe steatosis, that by definition means that there is more than 5% fat buildup in the liver. And this fat accumulates in lipid droplets within hepatocytes. But at the stage of steatosis, there is no concomitant inflammation or hepatocellular ballooning. Subset of those patients, approximately 20%, will go on to develop NASH or non-alcoholic steatohepatitis, where we will see fatty liver in addition to hepatocyte ballooning. Some of these patients, we may even see that there's an accumulation of an inflammatory cell infiltrate, but that is not necessary to establish the diagnosis. We do have to see hepatocyte ballooning, however. Some of those patients will go on to develop worsening fibrosis, cirrhosis, and hepatocellular carcinoma. And these are the sequelae we ultimately hope to prevent in our liver patient. According to the NASLD, weight loss is still the cornerstone for treatment of NASH. We don't have any therapeutics that are currently approved aside from what you'll hear about later, vitamin E and pioglitazone. And the AASLD does say that reducing calories is very important. They specifically write that weight loss generally reduces hepatic steatosis achieved either by hypocaloric diet alone or in conjunction with increased physical activity. And based on the evidence available, 7 to 10% weight loss improves most histopathology, even fibrosis. So what we don't know is what diet is best. What should we be telling our patients? Prospective trials comparing various macronutrient diets in NAFLD patients are quite limited by a lack of sufficient power. As well, many of them lack pre-treatment and post-treatment histopathology, so we can know that we are treating the disease. If we want to target ballooning and inflammation, we would recommend patients lose about 5% of their body weight. But if we want to target the more advanced histologic features of fibrosis regression or NASH resolution, we want to target 7 to 10% weight loss. What is less well understood and recognized perhaps by our viewers even here today is that not many of our patients can sustain this weight loss after a year's period of time. For example, for patients who are able to maintain or accomplish 10% weight loss, if we look at those patients after a year, only 10% or fewer are able to maintain that weight loss. So that makes it very challenging when we are recommending diets to patients. Adherence is going to be a very important factor. Regardless of those limitations and those realities, however, we do counsel all patients on healthy lifestyles, including changes in their diet and addition of exercise. We can also offer pharmacologic approaches for weight loss, but those require continuous medication use and monitoring. For a subset of our patients who are eligible for bariatric surgery, we can recommend bariatric surgery, especially if they have a concomitant metabolic disease that is covered for bariatric surgery procedures. And all of these approaches do work if patients lose weight and they correlate with NASH improvement. But given the lack of evidence on specific diets, what advice can we offer our patients to answer their questions about what to eat? They all want to know, well, what diet should I go on, doc? So today we're going to cover the topics that are most commonly encountered, at least in my own clinic. Patients want to know about low dietary sugar. Should they start using non-nutritive sweeteners? What about low fat or low carb? What is better? They have lots of questions about popular diets like the ketogenic diet. And finally, should they add vitamins to their regimen? We'll start with that first question. Should dietary sugar be limited in patients with NAFLD? Well, I'll share with you some epidemiologic data. The slide on your left looks at NHANES data from the late 1980s to the early 2000s and tracks the prevalence of obesity, NAFLD, as well as added sugar consumption of patients in the US. And what you can see, hopefully, is that these trends are really overlapping, suggesting that maybe sugar does have something to do with the obesity and NAFLD epidemic. But this study is association only. It does not talk about causality. Similarly, in the study on the right, when we look at patients who have a diagnosis of NAFLD versus those who don't have NAFLD, patients with NAFLD tend to have higher intake of sugary sweetened beverages, about a 2 times intake of sugar sweetened beverages. But again, this does not demonstrate causality. It's just an association. And let's talk about what we mean when we say sugar versus high fructose or starches, taking you back to the basics. When we talk about starch, these are complex carbohydrates, for example, polymers of glucose. Simple carbs or simple sugars are typically disaccharides that can include on a 1-to-1 ratio glucose with fructose. And when we say high fructose corn syrup, it's about 55% fructose containing substances, so not much more than a simple carbohydrate would contain. But it probably matters whether someone is ingesting glucose or fructose because the liver actually does metabolize these sugars differently. For glucose, the liver will generate liver glycogen, which is a storage form of glucose. It can also shuttle glucose to other tissues for energy. Fructose, however, cannot undergo that same metabolism, and most of the fructose metabolism contributes to de novo lipogenesis in the liver. That is the creation of new lipids, some non-lipid precursors. But the dose of fructose may matter. If we look at a mouse study, one that was published in 2008, a very nice physiology study where the researchers labeled fructose and examined the fate of fructose and its byproduct. They established that when they fed low-dose fructose to mice, most of that fructose was metabolized at the level of the intestine, and the liver saw very little fructose. Whereas when mice ingested high-dose fructose, that level of fructose overwhelmed intestinal metabolism, and the liver saw much more fructose, which again causes de novo lipogenesis. In addition, the microbiota saw more fructose and produced short-chain fatty acids, which have their own lipogenic effects on the liver. So at least theoretically, the dose of fructose may matter. But what about sugar, regular glucose? Is high sugar a problem? Well, sugar, as you know, raises insulin levels, and insulin, the hormone, acts on the liver to also promote de novo lipogenesis. It's one of the known roles of insulin. And high insulin levels have been demonstrated to correlate with NASH histology. Here in this study, we have 129 patients who had liver biopsy-proven NAFLD. 89 patients had simple steatosis, and 40 had NASH. And what's demonstrated by this study is that high insulin levels predicted the presence of NASH better than ALT. And we've known for a long time that ALT is not a good marker of either the presence or severity of NAFLD. But if you look at the second highlighted box, you can see that those patients who had low levels of ALT but very high levels of insulin had a 95% probability of having NASH on biopsy. And when they had both high levels of ALT and insulin, as demonstrated on the last box, almost with 100% accuracy, they were able to predict NASH histology on biopsy. So insulin levels appear to matter, at least in this study. What happens if we place subjects on a low sugar diet? Here is a study in adolescent boys published just this year in JAMA, where they had patients or subjects consume their usual diet or consume a low sugar diet. And by low sugar, this was less than 3% of their daily calories. And importantly, in this study, they had the whole family adopt this nutrition change, which in my own clinic, I think is very important for patients to have success with adherence to any diet, that the whole family try to adopt the same strategy. And they looked at these patients over just a 2-month time point, 0 to 8 weeks, and found that compared to adolescent boys who consumed their usual diet, those who were placed on the sugar-reduced diet had improvement of their hepatic fat, and this was as determined by MRI-PDFF. And these data have gotten a lot of attention, at least in the lay press as well, and so we are starting to think even nationally that sugars may be important in the risk of fatty liver disease. But should we make recommendations to our patient based on these very limited studies? Well, according to the AASLD guidelines, we cannot at this time make any specific recommendation for restricting sugars because we don't have enough data, we don't have enough large studies, and the studies are limited by the lack of pre and post biopsies. My personal opinion is that there's certainly excellent theoretical risks to limit sugar in patients with NAFLD, because we will limit the exposure not only to fructose, which promotes de novo lipogenesis, but also insulin in the case of high glucose containing diets, which will also limit de novo lipogenesis. And that will likely prove beneficial, but at this time, there's insufficient evidence to recommend limitation of dietary sugar. What about non-nutritive sweeteners? If patients can't have their sugar, can they substitute with aspartame or sucralose containing diets, for example? This question has not been very well examined in NAFLD. In the related condition of obesity, there appears to be a positive correlation between non-nutritive sweetener consumption and obesity, as well as type 2 diabetes, at least in the epidemiologic studies. But when these non-nutritive sweeteners have been used in dietary intervention studies, sometimes there's a neutral benefit, sometimes there's a beneficial benefit, so the data are not quite consistent. And part of the challenge with the epidemiologic data is that patients who are obese or type 2 diabetics are often advised to use non-nutritive sweeteners by their providers, so it's unclear if this is actually a true association or not. If we were to use a quasi-surrogate measure of NAFLD by looking at the ALT levels in the Framingham Heart Study cohort, they established that diet soda is not associated with elevated ALT when adjusting for BMI, but that sugar-sweetened beverages are significantly associated with elevated ALT in a dose-dependent manner when adjusting for BMI. When we look at the small NAFLD studies that have looked at sugar-sweetened beverages versus non-nutritive sweeteners, we don't have much data to share with you, but there are 2 small studies. One study is a 6-month study looking at 60 overweight or obese participants who were given different drinks. They were asked to drink 1 liter a day of either regular soda, milk, diet soda, which was aspartame containing, or water, and they measured their change in liver fat over time, over the 6-month period. And what they found was that subjects who consumed a liter of regular soda a day had an increase of liver fat, over 100% increase. Whereas those who consumed the other drinks had either improvement in their liver fat or reduction in their liver fat. This study, however, I should mention, is confounded because those who were drinking regular soda also had higher calorie intake and did not lose weight, unlike some of the other participants. Another small study looked at 12 weeks of 31 overweight patients and asked them to replace their sugar beverages with non-nutritive sweetener beverages. And similarly, they found that those who remained on their sugar-sweetened beverages did not have any improvement in their intrahepatic fat, but those who switched to non-nutritive sweeteners did have some improvement in their intrahepatic fat after 12 weeks. Similarly, in this study, there was a trend toward reduced calorie intake in those who were on the non-nutritive sweetener arm. Now, although we have no data to either support using non-nutritive sweeteners or to recommend against non-nutritive sweeteners in NAFLD patients, there's certainly some theoretical risks of promoting non-nutritive sweetener use in our NAFLD patients. For example, non-nutritive sweeteners have been demonstrated to activate sweet taste receptors at both mouth and extraoral site, perhaps changing taste preferences, worsening their insulin secretion, and even increasing appetite. There have been associations with alterations of the gut microbiome. And we also know or suspect that there may be differences between the different sweeteners, but we don't have data to tell us one way or another. Is aspartame the same as sucralose metabolically? Are there certain populations who may be more at risk for using non-nutritive sweeteners than other populations of patients? And finally, there have been inconsistent results when we look at both the human data as well as the animal studies. So to summarize the evidence in non-nutritive sweeteners in NAFLD, there are certainly theoretical reasons to avoid non-nutritive sweeteners, but practical reasons to use them as a substitute for sugar if used in moderation. But currently, we do not have sufficient data to either recommend or avoid these sweeteners in our NAFLD patients. What about our hypocaloric diets? We know that calorie reduction is important for weight loss ultimately, but should we be telling patients to limit carbohydrates or limit fat? And before I get to the data, I want to take you back in time. The Egyptians long known that if you force feed either duck or geese a high carbohydrate diet, you can create a fatty liver. And we call that gua, which is a delicacy that has been enjoyed for a long time by many. And the point is that the observation has been made that carbohydrates do promote fatty liver accumulation. Now, this is an apolitical talk, and I am very well aware of the debate going on with the potential animal cruelty considerations for our ducks and geese, and I am by no means recommending we use this as a model to study NAFLD, but just wanted to draw this to your attention that we may already have an inkling about how carbohydrates differentially affect the liver as compared with fat. But this has been studied experimentally. When stable isotopes are used to label fatty acids in patients with biopsy-proven NAFLD, we have learned quite a few important findings. For example, when we label dietary fat, most of that triglyceride ends up in the liver as a result of chylomicron production and degradation into chylomicron remnants, which are ultimately taken up by the liver and stored as triglyceride. We talked a bit about dietary sugar metabolism already. Most of that ends up in de novo lipogenic pathways, and triglycerides are formed in the liver on that basis. And finally, when we look at non-esterified fatty acids, most of which is derived from lipolysis of adipose tissue, those non-esterified acids are taken up by the liver and re-esterified as triglycerides. And these are really the three major ways that triglycerides accumulate in the liver. And when we label these fatty acids in humans with NAFLD, we find that most of the lipid accumulation in our patients is derived from non-esterified fatty acids circulating from adipose tissue and being re-esterified in the liver. That's about 60% of the fat contribution to the liver. But approximately a third of liver fat accumulation derives from de novo lipogenesis, which again is from the metabolism of dietary sugars. Dietary fat, on the other hand, is really only a small component of lipid accumulation in the liver, about 15%. Another study looked at labeling in subjects who had either low level or high level of intrahepatic fat, so presumably normal patients or NAFLD patients. And what they found was that, yes, de novo lipogenesis is the major component of liver triglyceride accumulation. However, in NAFLD patients, that contribution is even more pronounced as compared with our control patients. Therefore, these investigators advise that dietary sugar contributes more to liver fat than dietary fat. When we look at a meta-analysis of low carbohydrate diets compared with low fat diets, we are able to see that most of the studies do show a significant reduction in intrahepatic lipid content by about 12%. When investigators look at serum ALT or AST or GGT, those patterns may not necessarily be there, but they certainly see the reduction in hepatic fat. But this is not, unfortunately, the end of the story. The data get more complicated because when we look at head-to-head comparisons of low carb versus low fat randomized controlled trials, only one of those studies actually has demonstrated that a low carb diet compared with a low fat diet caused greater reductions in ALT. And they didn't even look at hepatic fat or other markers of NAFLD histology. Two of those studies really saw no difference. And both diets were able to support the reduction in weight in patients and improvement of various anthropometric measurements and metabolic endpoints. So initially there was promise of recommending a low carbohydrate diet over a low fat diet, but the results have been rather inconsistent. So the AASLD has not been able to recommend a specific approach to hypocaloric diet. What we do know is that losing weight is the key, and different patients may actually have different success depending on their independent risk factors. Whatever diet we recommend, however, we want to assure that the diet is at least a heart-healthy diet, because as we know, patients with NAFLD have more morbidity and mortality from cardiovascular diseases than from any liver cause. So a big question that comes up among our cardiologists, should we be recommending a low-carb diet over a low-fat diet for patients who have cardiovascular risk? For a long time, as we all know, a low-fat diet has been supported for our patients with cardiovascular disease because of the benefits on LDL and total cholesterol, which are risk factors for cardiovascular disease. And here's a meta-analysis of randomized controlled trials looking at this question, comparing low-carb and low-fat diets in overweight and obese subjects for approximately 1 year's time. And they found that each diet had different benefits. Low-carb diets were superior for improving the metabolic syndrome components that are very typical in our patients with NAFLD. So improving weight loss, raising the HDL, lowering triglyceride, and lowering blood pressure. But the low-fat diets were superior for lowering LDL and total cholesterol. What is really important that's come out of these studies is that the cardiovascular risk score was reduced by both diets, and even more so by the low-carb diet. So is it better to limit fat or limit carb for NAFLD patients? Well, there's certainly many theoretical reasons to limit carbs, but we really don't have enough studies to demonstrate that we can make this recommendation to all of our patients with certainty. The studies have not consistently demonstrated superiority in NAFLD. But we suspect that as long as simple sugars and total calories are reduced, weight loss is likely to be achieved. But ultimately, we have to individualize these recommendations based on our patient's preference, their ability to adhere to certain diets, and ultimately be successful with long-term weight loss. What about the popular diets? Are they beneficial in NAFLD? There are so many popular diets that sometimes I lose track, but thankfully my patients re-educate me on a periodic basis. And here's a chart up in the upper right-hand corner listing some of the popular diets that we hear about most commonly in our own clinics here. Each diet has its own proportion of macronutrients. Some of the diets really focus on this macronutrient manipulation. Some are high protein or low carb, for example. Some diets focus on timing, like the intermittent fasting diet, which is becoming more popular these days. Others focus on food groups like the paleo diet or gluten-free diet. They all have several factors in common for the support of weight loss. Adherence is important. They have to result in negative energy balance because that is how patients will ultimately lose weight. And a focus on high quality foods seems to be important for all of these diets. I wanted to spend a moment talking specifically about the Mediterranean diet, however, because this is the diet that we have learned the most about through the literature, the obesity literature, cardiovascular literature, and the diet that is recommended by the European Society guidelines, but our guidelines do not recommend this specific diet because, as you will see, we don't have enough data. So here's a study looking at a 6-week crossover style in non-diabetic patients who had biopsy-proven NAFLD. There were 12 patients. They were placed in either the Mediterranean diet arm or a low-fat but high-carb arm. And as a reminder, for those of you who are not as familiar with the Mediterranean diet, this is a diet that's really high in fruits and vegetable consumption, whole grains, less on meat and dairy. So very different from a typical Western diet. And the results of the small study demonstrated that there is a reduction in hepatic fat for subjects who are on the Mediterranean diet as compared with the low fat but high carb diet. And also, we talked a bit about insulin earlier in today's talk. The insulin levels were significantly lower in subjects who consumed the Mediterranean diet over the low-fat but high-carb diet. In NAFLD, there's an observational study that took place over a 6-month time period where patients were placed on a Mediterranean diet intervention. They had monthly nutrition counseling, and there were 46 patients. Compared to baseline, 20% of patients had resolution of steatosis by the 6-month time point, and the majority of patients had improvement in their steatosis overall, and few patients had severe steatosis over a grade of 2 by the end of the study. Only 9% of them had severe steatosis. So at least in this observational study, there did seem to be some benefit of the Mediterranean diet. What about the ketogenic diet? Many patients were coming in asking, should they go on a purely ketogenic diet? Should they do a modified ketogenic diet? We really don't have much data in NAFLD, but there are some studies that I'd like to share with you as sort of surrogates for NAFLD. This is a non-randomized open-label trial of a year-long ketogenic diet intervention, 262 patients, so a very large patient population, and 87 usual care subjects. These patients had type 2 diabetes and obesity, and they had moderate alcohol consumption. And a word about this, we are definitely recognizing for those of us who take care of these patients, that pure NAFLD patients is becoming uncommon, where patients aren't consuming alcohol. And it is important that we start to gain data about patients who not only have the NAFLD metabolic risk factors, but also the alcohol metabolic risk factors. And so here's a study that attempts to do that. So they looked at these patients over a year period and measured the normalization of ALT as their endpoint. And what they saw was that for patients who achieved a mean weight loss of about 13%, they had tended to have improvements of their A1Cs over 1%, and that correlated with normalization of ALT at the 1-year time point. These patients did not have liver biopsies, so we cannot say with certainty that this reflects improvement in NAFLD, but they did try to get at that question by using surrogate markers of NAFLD by looking at the liver fat score and the NAFLD fibrosis scores, and those had similar trends as what we see with the ALT improvement. There's a pilot study of 5 patients who were placed on a ketogenic diet for 6 months. These patients were obese and had biopsy-confirmed fatty liver disease. And what they saw was that 4 out of 5 patients had weight loss and significant improvement in all 3 histology grades. This corresponded with improvements in steatosis, inflammation, as well as fibrosis. And only 1 patient failed to lose weight and ultimately progressed their liver disease. Other diets, we don't really have much data about either, like the DASH diet. There's an association with a lower prevalence of NAFLD, and that diet is very similar to the Mediterranean diet. We have no information about commercial weight loss products that are listed here. We know that patients lose weight, but the data are really lacking. There's been a lot of enthusiasm for the intermittent fasting regimens, but we really lack data for those diets as well. To summarize the popular diets in NAFLD, really none has high quality evidence, none that we can recommend in hepatology and certainly by our society for use in all patients who have NAFLD. The key is likely to be patient preference and ability to adhere. The Mediterranean diet does appear to be a good choice for a balanced diet, with of the diets, at least that have been examined, the strongest evidence so far. But even there, the data are not robust enough to recommend this for all patients. There may be a role for use of the more restrictive diets, at least in the short term, but adherence is probably quite difficult, and long-term data, again, here are lacking. Finally, what about vitamins and supplements? Are they advisable in our patients with NAFLD? We wrote a review recently talking about micronutrients in NAFLD patients, and the liver is involved in micronutrient metabolism, whether that be vitamins or minerals. The liver is involved in transport and storage of many of these micronutrients. And in NAFLD patients, many of these patients have low levels in their blood of zinc, copper, vitamin A, vitamin D, and vitamin E, although we don't understand the specific mechanisms why. And low levels of these vitamins have been associated with NAFLD severity. Again, we don't understand the mechanisms. So vitamin supplementation theoretically may have benefit in NAFLD, as many of them have antioxidant, antifibrotic, immune, and lipoprotective benefit. So with the exception of vitamin E, no vitamins are approved to treat our NAFLD patients. I'd like to review for a moment the seminal trial, the Pippin's trial, published in 2010, where they looked at pioglitazone and vitamin E in patients with biopsy-proven NASH. These were non-diabetic, non-cirrhotic patients. And hopefully you can appreciate here that compared with placebo patients in red, the vitamin E arm patients in blue had improvement in their histologic features of NASH, a trend toward improvement in fibrosis, and has significantly improved in resolution of NASH in patients who were biopsied. So according to the AASLD, vitamin E is an approved therapy for non-diabetic adults with biopsy-proven NASH. Again, these patients should be non-cirrhotic, but again, here we should discuss the risk and benefits of therapy with each patient. Vitamin D is not recommended currently for the treatment of NAFLD, but may have some utility in the future. Patients who are obese are recommended by the Endocrine Society to be screened for vitamin D deficiency, as many of them do have low levels, and recommendations are to treat them if their levels are less than 20. Theoretically, the vitamin D receptor is part of the fibrogenic pathway in hepatic stellate cells. And so targeting vitamin D may be of utility in the future, but we have no studies in NAFLD, but several studies are underway. In a related condition of polycystic ovarian syndrome, there was a randomized double-blind placebo-controlled trial of vitamin D supplementation in women for over a three-month period, and they did see reductions in ALT. Again, it is unclear if these patients had NAFLD or not. To summarize vitamins in NAFLD, vitamin E is the only vitamin that is recommended for non-diabetic adults with NASH, but we should consider the risks. And vitamin D replacement theoretically may make sense in those with deficiency. So we are going to go back to our pre-questions. The first question, if following AASLD guidance, what is the minimum weight loss goal you would recommend to reverse fibrosis in NAFLD? 3 to 5%, 7 to 10%, 13 to 15%, 17 to 20%, none of the above, or unsure. We'll take a few moments to vote. Most of you got the 7 to 10% answer. 7 to 10% weight loss reduction has been associated not only with improvement in inflammation and NASH histology, but also in fibrosis. And we didn't always know this. We used to think that once fibrotic, always fibrotic, but we now know even fibrosis can regress if patients are able to achieve at least 7 to 10% weight loss. So that is the minimum weight loss goal that would be recommended. Next question. Which approach has been shown to be consistently superior at improving features of NAFLD? Limiting non-nutritive sweeteners, limiting carbohydrates, limiting fat, the Mediterranean diet, ketogenic diet, vitamin D supplementation, none of the above, or unsure. We'll take a few moments. Okay. So just to recap, we still have several of our viewers responding about the Mediterranean diet and limiting carbs. None of the above is the correct answer. The key here with this question is consistently superior. There are certainly data in a number of these categories, but none of these data have been consistently shown to be superior in NAFLD. And a lot of the limitation is because the studies are underpowered. We don't really have head-to-head trials in a lot of these areas. And also the subjects who are participating in these trials have not had pre and post biopsies to help us understand if their histology has been improving with NAFLD. Some of you responded that the limiting carbs has been consistently superior, and it is true that simple sugars and total calorie reduction can be achieved by limiting carbohydrates, but it's unclear if carb reduction or low fat or fat reduction is really key based on the studies that we have. The ultimate key is weight loss, and we have to individualize to patient preference. Go over that summary a little bit further. There are certainly theoretical reasons to limit sugar, especially fructose, and with non-nutritive sweeteners, some theoretical reasons we may avoid and some practical reasons to use them in moderation. But really, no diet has demonstrated consistent superiority, and we have to individualize these to patient preference. As far as the vitamins, only vitamin E has been established to be beneficial for non-diabetic adults with NASH, but we of course have to still consider the risks. So what is my approach? I talk to patients about healthy eating instead of dieting. The Mediterranean diet is something that some patients may derive benefit from. The European guidelines do certainly support it. So if there are members joining us internationally, that is part of your guidelines. The Harvard Healthy Eating Plate is visual that I share with patients because it helps them understand the proportions of vegetables compared with healthy protein, et cetera, that they should be striving for on their meals. We do recommend that they minimize or eliminate sugar-sweetened beverages because it's a high-calorie source, and sometimes targeting that alone can get them to the hypocaloric diet that we are striving for. Using healthy oils, portion control, minimizing going out to restaurants as much as possible if their lifestyle can accommodate that, but especially avoiding fast food because sometimes a burger can be 1,300 calories by itself, and that's probably not the only food they're going to have for the day. And finally, avoiding eating at night because there's not opportunity to extend those calories as easily. Thank you very much. I'm open to questions. I'll start with a question that does come up a fair amount. We focused mostly on obese patients with NAFLD or NASH today, and I have a question: what about thin patients with NASH who should not lose weight or cannot lose weight? And I can only talk about my own practice pattern. This is another data-free zone. What I find oftentimes, even in patients who I perceive to be thin by our usual metrics, probably do have increase in their visceral adiposity. And so even for them, when they change their diet, they will have improvements in their visceral adiposity that can subsequently improve their liver disease. I often take a very detailed exercise history in these patients in particular. And I'm finding, at least anecdotally, and again, I don't have any data to support this observation among my own patients, that many of those patients were once athletes, or maybe they had changes in their lifestyle that prevented them from going back to such a rigorous routine. And in this subset of patients, I tend to recommend exercise more heavily than, say, patients who maybe never were athletes and can't really get to exercising at that level again. But I do still recommend dietary approaches. I can usually figure out in their diet something that they can alter to improve their NASH. Another question I have: do all patients with fatty liver have the same risk for NASH? And the answer is no. Only about 20% of patients who have hepatic steatosis progress to NASH. And we are still working on understanding which of those patients are, why patients, only that small subset, have an advanced progression. We do know that patients who are pre-diabetic, diabetic, or insulin resistant are more likely to have NASH than not. Certainly patients who are obese and non-obese. We don't really know the exact answers for why not 100% of patients progress to NASH. And so how do you distinguish these high-risk patients in clinical practice? Well, we rely on several things. Those factors I mentioned before, whether they are pre-diabetic. I do a fasting insulin and glucose in all patients to establish the diagnosis of insulin resistance. If they have non-invasive markers that suggest they may have fibrosis, whether we're talking about the blood biomarkers or the elastography modalities, that may suggest that they have more advanced disease. And of course, liver biopsy is still part of the paradigm to ultimately establish who these patients are. Another question, am I utilizing fasting with any of my patients as a way to restrict total caloric intake? I don't specifically recommend the intermittent fasting diet. What typically happens is that patients come to me and they have started an intermittent fasting diet and they want to know from me, is it something that I would, recommend for or against? And I really do individualize this question. If it's a diet that has been working for them, I try to support them through it. I make sure that I'm monitoring their lipids and their sugars and doing closer monitoring while they're on this diet. And I also caution them that this may be an approach that it may be difficult to sustain long term, but for short-term trials, I have no objection to those diets. I think one of the key things in metabolism is that our bodies are really work best when when we allow our insulin levels to go low and then they go high. Like, our bodies are used to this cycling of insulin. So if we have patients who are eating all day long and never letting their insulin levels drop, that becomes pretty deleterious physiologically for the body. And so intermittent fasting, at least theoretically, in my view, does accomplish that period of relatively low insulin levels in the body. But there are certainly other strategies that can do that as well, like not snacking during the day and eating only when feeling hungry. A question about milk thistle. This question comes up a lot as well. Vitamin E is an approved supplement, but what about milk thistle? Milk thistle is not an approved supplement for any of our liver diseases. It has been used for a long time. For example, in patients who had hepatitis C, often I would find that they are also a milk thistle. It tends to be a pretty innocuous substance or supplement, so I don't tell my patients to come off of it. But I also let them know that I don't think this is going to help their fatty liver disease. We certainly just don't have any data that it would be beneficial in this case. I have a question about what is the average ALT that NASH patients should have, and there's no answer to this question. ALT is not part of the diagnosis for NAFLD. Patients can have a normal ALT and have NAFLD. They can have a normal ALT and have advanced NASH. So we actually don't use ALT in that way to figure out what patients should have on average. Some of the studies have used ALT as a surrogate measure because the majority of patients do have abnormalities, although it's not always the case. And in an effort to limit liver biopsies in studies, or if they don't have access to biopsies, sometimes the ALT in combination with metabolic risk factors will be used as a surrogate measure, likely NAFLD. I have a question, are people able to successfully follow dietary instructions without a dietitian helping them? I love this question because we are oftentimes faced in our institutions with having to figure out how best to apply our resource dollars. And I am a really big proponent of utilizing dietitians for our patients, especially those who have metabolic diseases like NAFLD. The reality is that we don't have enough dietitians, and our patients, even when the dietitians are available, don't always have access to them. And so it is a big limitation in our field. That being said, I do think there are some patients who can have success without being under the care of dietitians, but I think if we had unlimited resources, all of our patients should at least one time see a dietitian to help them in managing their disease. So one of the things that I help patients try to understand in terms of achieving their either sugar reduction or calorie reduction is that they don't necessarily have to count every single calorie they're consuming per day. For some patients, that works for them because they really want to know their exact numbers, and without that close attention, they are unable to be successful. But for many of my patients, that task can be quite onerous. So I give them what I call in my own clinic, the 50% rule. And I'm not sure if I made it up or, someone else wrote about it somewhere, and I would certainly give credit if I were aware. But I use the 50% rule a lot in my clinic for patients who cannot go to a dietitian to understand exactly how to change their diet. And by that, I take a very detailed dietary history. I understand what their typical breakfast, lunch, dinner meals are, what their snacks are like. And I try to figure out with the patient areas that can be adjusted, especially in terms of the sugar and carbohydrate intake, which I find in my own clinic are typically the biggest categories of food intake. And for 50% reduction, I have them think about it by meals. If they're eating 4 times a day, I say, well, 2 out of those 4 meals, I don't want you to have sugars or carbs. And for the other 2, you have your normal sized meals. Or I have them establish during the week, 3.5 to 4 days, they're going to really work on not having those extra carbs or sugars. And then the other days they can have their normal meals. And some of my patients really like that approach because it's like a simpler way to think about meal planning. Is there a biomarker that we can check for NASH? Doesn't look like the ALT is a good indicator, but many studies use it as an endpoint. That is really an area of active research. It has been for many years. We don't have a great biomarker of NASH severity, but I think hopefully over the next few years we will get closer to that. So really it's a combination of things, obviously taking the history of your patient. Family history does appear to be important, by the way, if they've had a relative with NASH cirrhosis. That always raises my antenna. We do use the ALT. I mostly use it because it's motivating to patients. If they come in with a high ALT and they have improvements that correlate with their weight reduction, patients are really motivated by that. We talked about the non-invasive biomarker panels and elastography metrics as well that can be used. There's a lot of research going on now and other radiologic tools that hopefully will supplant the need for liver biopsy in the very near future, but we really don't have any great biomarkers that I can recommend. CBD oil is another question. Is there any data on CBD oil and liver health? And I did have opportunity to review this question about a year ago. And so far, from what I can tell from the literature, it is not harmful for NAFLD. There's certainly nothing that I can recommend at this time for treatment of NAFLD. But so far, at least in the short studies that have been done, we haven't seen any harm of CBD oil. It doesn't mean that there's benefit of CBD oil, but certainly there's some smaller studies that have shown metabolic benefit in a subset of patients. But I cannot at this time recommend its use for treatment of NAFLD. Is pioglitazone a good treatment for NAFLD? Pioglitazone is a medication that is approved for biopsy-proven NASH, and it does work, as we have seen in the PIVMS trial. The challenge may be some of the side effects of pioglitazone. It does cause weight gain in areas that patients, unfortunately, can be pretty self-conscious about. And so it isn't something that I've personally prescribed in my practice because of those side effects, but it is recommended as one of the treatments we can use for patients who have biopsy-proven NASH. Of course, those patients can be either diabetic or non-diabetic. In referring to the studies comparing low-carb and low-fat diets, do both groups have isocaloric intake? And that's an excellent question, and I tried to bring forward some of that in some of the studies so the answer is not always. Sometimes there are differences in caloric intake, and so it's really hard to interpret whether these studies are showing benefit or not. But I do agree that for any of these dietary intervention studies in NAFLD, that isocaloric diets need to be compared, because it could just be that reduction of calories by any means necessary is what the answer is ultimately. But we really want to know if it's the macronutrient that is playing a role. I'll take one last question. Could pharmacotherapy for weight loss be advised together with dietary approaches? And I think the question to that is probably yes. Again, we don't have in NAFLD really any great studies that have looked at this question, but practically speaking, when my patients see our dietitian and our GI nutrition specialist, they are often given pharmacotherapy in addition to dietary recommendations. So those studies certainly need to be done. Thank you for your attention, and we'll be ending this session.
Thank you very much, Dr. Carr, and thanks to your listeners for joining in. As a reminder, to hear more about NASH from Clinical Care Options, click on the link in the show notes. Please be sure to check back regularly for more episodes on important topics. Thanks.